Welcome to Rumor versus Truth, your trusted source for facts. We dissect the evidence behind risky rumors and reveal clinical truths. Today, we'll gab about rumors around gabapentin.
Hey, Steve. Let me ask you a question. Have you ever looked at a medication list and thought, you know, why is gabapentin on here for everything?
Yeah, it feels like that. Nerve pain, yeah, restless legs, sure, sleep, anxiety, your cat's going crazy. Also, yes, yeah, it's everywhere.
Right, right. Yep. And to put it more in construction terms, it seems like it's like the duct tape of the pharmacy world. Uh, Today, we're separating what's legit from what's just been flying under the radar, including some safety claims that don't always make it into the conversation.
And some of the claims out there about the sedating med can be quite jarring.
Yeah. This episode definitely won't make you fall asleep. With that, I'm your lively host, Don the Pharmacist.
I'm Steve, the pharmacist, and this podcast offers continuing education credit for pharmacists, pharmacy technicians, prescribers, and nurses.
Yep, just log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast in the list of available CE courses.
And for the purposes of disclosure, none of the speakers today have anything to disclose.
Right. So, gabapentin, quite a story to tell, right? So, let's back up a bit here. Um, gabapentin started as an anti seizure medication approved by the FDA in 1993. And is strictly similar to the neurotransmitter, the gamma aminobutyric acid, or GABA for short, right? So, this neurotransmitter slows down nerve firing, which can decrease dysfunctional signals in the brain that we see with seizures.
That's right. And we also see dysfunctional firing in nerve related or neuropathic
Mhm.
pain. That's why gabapentin is also approved for post herpetic neuralgia or nerve pain after having shingles, which is pretty specific. But the reality is, gabapentin is now used far beyond seizures or post herpetic neuralgia. In fact, about 8 in 10 US gabapentin prescriptions are actually for off label uses. But is this med really a jack of all trades?
I do see gabapentin all the time. Uh, I actually see this med so often for other neuropathic conditions, I never thought of it being not approved for them. And when one medication shows up on medication lists for pain, sleep, anxiety, restless legs, you name it, it becomes really easy for rumors to take root. And I think some people see it as a cure-all. Others see gabapentin as a hidden danger. And both extremes really miss the real story. This actually has been a problem for gabapentin. Its manufacturer paid over $400 million in the mid 2000s to settle criminal and civil lawsuits over illegal advertising for unapproved uses. Things like bipolar disorder, attention deficit disorder, and migraines.
Wow. Well, this topic is already getting quite unnerving. Love it. But that kind of history tends to linger in the background even years later, obviously.
Mhm, mhm. So, between widespread off label use, you have the mixed evidence and a lot of association based studies that don't prove cause and effect. It's no surprise gabapentin has become a magnet for bold claims. Today, we're going to separate which concerns are valid, which are overblown, and where the real caution belongs.
Right. And now let's start with why gabapentin is on so many med lists for pain. The claim is gabapentin is modestly effective for neuropathic pain.
Okay, modestly effective. Seems like it's doing a lot of work there.
Yeah, I agree. And a nice way to quantify modest here is with the number needed to treat. So, for example, in post-herpetic neuralgia, a past meta-analysis, so a group of studies all kind of combined, found that about 7 patients need to take gabapentin for at least 2 weeks for just one patient to get at least 50% pain relief, which is considered meaningful pain relief. Now, for diabetic neuropathy, the number needed to treat is a little lower, about 5 to 6, which is considered a little bit better. But overall, for a few people, it's a decent win. But for many
Mhm.
patients, it's not based on these numbers here.
Okay, so to unravel your nerdy talk there, and for someone in practice, what does it mean for them?
Yeah, to boil that down, it means gabapentin may help, especially for true neuropathic pain syndromes
Mm,
such as diabetic nerve pain or fibromyalgia, but we should set expectations. Again, it's only FDA approved for post-herpetic neuralgia. but we know it's commonly used for other pain syndromes that, based on this, frankly, have less evidence.
And dose wise, I think a lot of clinicians assume that more is better. That's true pretty much with a lot of pain medications. Uh, but keep in mind that gabapentin, I'll be the nerdy one now, is the gabapentin absorption is saturable. So meaning absorption drops as the dose goes up. A good way to think of it is like a sponge. Once it's fully soaked, pouring more water onto it doesn't really make it absorb a whole lot more. Most of it just seems to run off. Gabapentin works in a very similar way. Once the gut hits its absorption limit, much of that extra dose doesn't get into your bloodstream. It just pretty much gets wasted.
Right. When we look at 900 milligrams a day, we see absorption at only about 60%, and it goes down to 34% at
Mm,
2,400 milligrams a day. So you kind of
mm,
see that trend there. And
right.
in its labeling, studies in postherpetic neuralgia didn't show much benefit when using doses above 1,800 milligrams a day, even though patients have taken much higher doses that I've seen in practice.
Right. And I do see that higher than that. And above that dose, you might just be increasing the risk for adverse effects.
Yeah, and not all pain is alike, so gabapentin isn't a universal cure either. For
Mm,
example, you may see gabapentin is sometimes used for low back pain that doesn't involve things like a pinched nerve, but the evidence for gabapentin there is particularly weak, and it actually seems to perform similar to placebo, according to studies. So, if we're not treating neuropathic pain, we should be careful about reaching for neuropathic pain meds, right?
mm, Yep, good. And when patients aren't seeing that meaningful benefit, we should double check that they optimize those non-drug therapy options to help with pain. What comes to mind is like physical therapy, aerobic exercises, swimming is one of them. So,
Yeah, definitely good to point those out. So when it comes to this
mm,
claim that gabapentin is modestly effective for neuropathic pain, the verdict is true. The practical takeaway here is set expectations early and prioritize a close pain reassessment. And if you don't see meaningful benefits, don't just keep titrating that gabapentin up forever.
yeah, true. If the patient is already on higher doses, keep an eye on adverse effects like dizziness and excessive sleepiness. Drowsiness when starting or titrating doses is more common, but it should prove within 2 to 4 weeks. And remember that doses of up to 800 milligrams per day, added benefit may be limited.
I like that. And consider pregabalin as a possible alternative here. It's closely related to gabapentin, hence the name, but it has more predictable pharmacokinetics. Its absorption is 90% or higher, and it doesn't have that saturable issue that you're
Mm.
talking about, Don.
And I believe evidence suggests pregabalin works faster, has the benefit of having a narrower dosage range, and it can be titrated faster. And keep in mind that pregabalin is FDA approved for diabetic nerve pain and fibromyalgia, whereas gabapentin is not.
And to help ease the pain of deciding neuropathic pain options, use our pharmacotherapy of neuropathic pain as well as our treating fibromyalgia charts.
Cool. All right. Now we talk benefits, right? So what's the other end of it? It's risks. And here's a big one that comes up with patients and clinicians. The claim is gabapentin is addictive.
Yeah, that can be a scary claim. And this is where terminology matters a lot. So when people say addictive, they often mean
Mhm.
very different things, right? It can be tricky to tease this out from other terms like dependence.
Right. So let's tease out now. So clinically, addiction has a specific definition. It's a treatable chronic medical condition, and it's impacted by many things, brain circuitry, our genetics and environment, and the patient's life experiences. Uh, People with addiction use substances or engage in behaviors that are compulsive, and they often continue those behaviors despite harmful consequences.
And gabapentin doesn't really fit that profile when I think about it.
Mm,
It isn't proven to strongly activate the brain's dopamine reward pathway
mm,
the way that opioids, alcohol, and stimulants do when we think about
mm.
those. There's no real high driving people to seek it out compulsively on its own.
Right. Let's look at the other end now, which is physiological dependence. And that's different. Patients may end up depending on a medication to avoid withdrawal symptoms if they stop abruptly. In the case of gabapentin, withdrawal can involve like seizure, agitation, things like that.
Yeah, and if gabapentin is being discontinued, product labeling recommends tapering it over at least a week, exactly to
Mm,
avoid those symptoms. So I'm glad you pointed those out.
yep. And there's also reports of withdrawal that can look a bit like alcohol or benzodiazepine withdrawal. But there isn't good evidence that gabapentin leads to cravings or that psychological inability to quit. In this case, withdrawal is real, but withdrawal does not equal addiction.
And I'm sure some of the audience is now wondering, then why is gabapentin a controlled substance in my state?
Mm, yep,
Some
yep,
states
yep.
do, in fact, have it as a control. Plus, certain states require gabapentin prescriptions to be logged into their prescription drug monitoring program or PDMP to
Mm,
track use, even if it
mm,
isn't a controlled med in that state. And this is mostly because gabapentin can be misused. For example, some patients may use illicit gabapentin supply or higher doses than prescribed to boost the effects of other substances, such as opioids.
yep. Speaking of that, opioids. When you combine gabapentin with opioids, you raise the risk of respiratory depression overdose, as we all know, can be deadly. Uh, the 2017 study showed that 50% increased risk in opioid-related deaths when gabapentin is co-used. But remember, this misuse issue doesn't necessarily mean gabapentin is addictive. So, get the answer away, but going back to that claim, gabapentin is addictive. The verdict is rumor with conditions. The nugget here is don't jump to viewing gabapentin as addictive, but do keep dependence and withdrawal risks in mind and taper carefully when planning to stop therapy.
And gabapentin may not be a good choice in a patient with
Mm,
substance use disorder history. This may be a good scenario to think about other neuropathic pain alternatives. Things that come to mind maybe duloxetine or venlafaxine.
yeah, those are good ones. So, and also continue to follow your state laws and pharmacy policies around gabapentin to prevent and address diversion and misuse.
And check out our controlled substance prescription validation CE course for more details. We know there's lots of documentation and liability involved with these meds.
That is a great course, and biased, I did update it, so put that out there. And one common point of confusion to clear up really, opioid reversal agents like naloxone or nalmefene will reverse opioid effects in an overdose, but they won't reverse sedation from gabapentin alone. If there's an overdose with both on board, naloxone or nalmefene can still be life saving for an opioid part, but patients may still need oxygen to help with gabapentin if gabapentin is still having an effect.
Yeah, very true. And next up, a scary claim that's been getting attention in the last couple years is that gabapentin causes dementia.
Very strong and punchy claim causes dementia, but what does the evidence actually say with that?
Yeah, the short version here is there are observational studies showing an association. Others don't. And the designs
Mm,
make it hard to tease apart cause and effect. For example, a 2023 matched cohort study from Taiwan found higher dementia risk in people prescribed gabapentin or pregabalin. And the signal looked stronger in patients under 50 years old. So that's interesting. And a 2025 retrospective cohort study in chronic low back pain patients also reported increased dementia and mild cognitive impairment diagnoses in patients who were prescribed six or more gabapentin
oh,
prescriptions.
right. So going back to the word association, all hammered in saying association does not mean causation, right? And to establish causation, we would need a randomized control trial before we could say causation, right?
Yeah, you're absolutely right. These study
Mm,
designs that they used are vulnerable to effects from other factors that can impact the outcome. People prescribed gabapentin may have more chronic pain, more comorbidities, taking other medications that may have links to dementia risks, or things like more depression or sleep problems. And those
mm,
factors themselves can impair cognitive outcomes, as we know.
mhm. And there are many factors we got to need to control for to really get solid results, which only a randomized controlled trial can do.
Right. And plus, just because someone has a prescription for gabapentin doesn't mean they actually took it. So you have to take that
Mm,
into account. Plus, this association isn't even seen across all studies. One study looking at adults 50 and older with chronic pain
mm,
didn't find a higher dementia risk with gabapentin after
mm,
adjusting for other factors. And they also didn't see a rise in risk with increasing doses, which you would expect if there was an issue, right? So there is a decent amount of evidence here that there isn't an association either. So when it comes to this claim that gabapentin causes dementia, the verdict is rumor. So some observational studies show an association, but others don't. And the designs don't allow us to say that it's a cause. So there isn't evidence that gabapentin causes dementia here.
Mhm. Right. And importantly, the risks, I worry about aren't dementia decades later. It's what's in the now, which is sedation, confusion, and the falls. This is especially true for our older patients. Gabapentin is noted on the Beers criteria list for them. I think, for example, it mentions high risk in elderly patients with kidney dysfunction and also flags that opioid plus gabapentinoid combinations can increase risk for sedation and respiratory depression.
Good point. And I would say those are more clear and present risks than dementia
Mm.
here. And we have our potentially harmful drugs Beers criteria chart as a handy reminder of risky meds to watch out for, including gabapentin. But if a patient tells me, well, I saw on TikTok that gabapentin causes dementia, my response isn't a knee jerk, well, that could never happen.
Mhm.
It's we're looking for stronger data and we're waiting for that. In the meantime, we should use the lowest effective gabapentin dose, adjust for kidney dysfunction, and obviously reassess those pain benefits.
Right. Of course, you're on TikTok, Steve. Uh, Getting back to it, and if a patient, gets foggy or unsteady or overly sleepy after starting or increasing gabapentin, you know, may want to weigh decreasing the dose and scan for other meds that could be the culprit. These also could include drug interactions with other sedating meds.
I agree. And if the med isn't clearly helping with pain or function, considering tapering it off and switching to another med
Ugh.
rather than just letting it ride indefinitely on that med list.
All right. All right. Now let's take a ride along to everyone's favorite segment, Fast Facts.
And this is where we jump into some common bite sized claims about
Mhm.
gabapentin and give them a seal of approval or debunk them quickly.
So, first up is gabapentin is associated with increased risk of cardiovascular disease. And the verdict is true. Gabapentinoids have been linked to higher rates of cardiovascular events like heart attacks and stroke in observational studies, but this only shows an association, not proof of cause. But still consider baseline cardiovascular risks, potential edema and weight gain, overall medication burden when choosing therapy.
Right. And next up, gabapentin is effective for generalized anxiety disorder. And the verdict here is rumor. Gabapentin is sometimes used off label here for anxiety, but we don't have randomized controlled trial evidence around using it for generalized anxiety disorder. It shouldn't be a first line option, so stick with therapies that have stronger evidence. For more on choosing alternatives and managing risk, we've linked to several evidence based resources in our show notes.
Well, glad we could take those for a spin. Now, this next claim is a serious one.
Right. And before we move on, we want to let listeners know that the next segment will discuss suicide and mental health. So if this topic is sensitive for you, please take care of yourself and feel free to skip ahead. If you or someone you know is struggling, help is available. Call or text 988 or check our show notes for more resources.
Yeah, thank you, Steve. So, the next claim is gabapentin is associated with suicidal behavior. And when we talk about suicidality, we have to separate three things. The first one is the underlying condition, things like chronic pain, depression, substance use. Second thing is the medication itself. And lastly is what the data can truly prove. So I reached out to one of our specialty consultants, Dr. Adam Kay, to help us explain this. He's a clinical pharmacist and pain specialist who's published several papers of gabapentin. Let's see what he had to say. Hey, Adam, welcome to the podcast. Glad to have you on. I was a little apprehensive on bringing you on since you're a Lakers fan, but I guess we'll look past that and go to the expert here. So, this particular claim is gabapentin is associated with suicidal behavior. What are your thoughts on that?
Well, I would say since 2008, the FDA has made it very clear that their analysis of thousands of patients and 11 anticonvulsants, that there is a strong association between the risk of suicide and antiepileptics, including gabapentin. So I think it's absolutely reasonable for there to be a black box warning, which we now just call a boxed warning, and an FDA med guide requirement for each dispensing.
Uh, do you so you said they're the boxed warning on there. Do you have, like, numbers or percentages of the association with, suicidal ideation?
Yeah. Um, British Medical Journal and Lancet, they've done a lot of studies where they've identified pre-existing um, mood and suicidal ideation risks. And we know that people that use gabapentin, for example, they also might have comorbidities, including anxiety, depression, insomnia, chronic pain, and all of those contribute to lots of suicides and lots of self harm. So I think the statistics absolutely show a higher risk in people that use gabapentin. And I think that it's absolutely necessary for pharmacists and prescribers to suggest to patients that they read these med guides and they think about it. Is my mood, you know, getting bad? Am I being mean to my spouse and my kids and my coworkers? So we absolutely should keep in our mind that gabapentin is associated with self harm, and we should monitor the patients closely because of this.
Perfect, okay, so that's what you would that medical professional talking to that patient, you know, if they bring up that question, "Hey, is this could I have a worsening mood?" The answer is, "You could," basically on this, and especially if you're already, predisposition to, depression, that kinda stuff, that could potentially make it worse. Correct. Mm,
Absolutely. As a pharmacist clinician, when I would initiate gabapentin, I would always initiate it with a low dose. There's absolutely no rush to start someone on 300 TID, for example. But you have to make sure the patients understand that there could be fluid retention, weight gain, respiratory depression, and all of these things are additive. And the med guide goes over all of this. And there's no reason why a pharmacist can't use the med guide to help them with the patient consultation. Patients are in a rush. They certainly aren't taking notes. That they're listening to the best of their ability. But I think the med guide, absolutely, you could point, you could highlight, and you could let the patient know that there are risks
right.
associated.
I think, going back to consultations on gabapentin myself in the pharmacy is letting that patient know to let their families know too. Sometimes they don't know themselves that they're worsening condition because they're too in it, right? And to let their spouse, children, whoever lives in know, "Hey, let me know if my mood is worsening." Would you kind of agree with that as well? Yeah.
Absolutely. It's sort of like with opiates and naloxone right now. No one expects a patient to utilize naloxone themselves if they lose
Yep.
consciousness.
Good one.
We know right now that the world is pretty opioid phobic. So I mean, we have to believe that 80% of all the gabapentin or more is being used specifically for chronic pain. And these people have lots of comorbidities. We know that insomnia is very prevalent with chronic pain, depression and anxiety, and financial
Yep.
problems, ED. I
Yep.
mean, the list goes on
Mhm.
and on.
Yep. It's all additive. So I love the naloxone analogy. Thank you for that. So, yep.
Anytime.
So thank you for joining us. Great answers, and talk to you next time. Thanks.
Okay, it's been a pleasure. Thank you so much.
Really good points there. I'm glad you got to talk with him, Don. And that's actually a really good reminder that I even needed to counsel patients and
Mm.
caregivers to watch for new or worsening depression, agitation, or suicidal thoughts, and to contact a clinician right away if those occur. And I think about alternatives if a patient is unstable or has untreated mental health concerns.
Yep, all good points. So going back to that claim, which is gabapentin associated with suicidal behavior, the verdict is true with conditions.
Yeah, I would treat this label warning like a monitoring prompt, not a
Mm.
guarantee. But ask about mood at baseline, recheck after starting or titrating the med, and make sure patients know what symptoms should trigger an urgent call.
Right. And also, another good point is when dispensing gabapentin, ensure patients are receiving that FDA required medication guide with every fill to ensure they're informed about proper use and risks.
And the bottom line truth here today is that many of the concerning claims around gabapentin don't tell the full story. Some are rumors, some
Mhm.
show associations without proof of cause, and none mean the drug should be avoided wholesale.
Right. The takeaway here, or whether here or anywhere else, is gabapentin isn't a bad drug. Its proper use depends on what we're using it for, the dose, and how we monitor it.
Yeah, so when you prescribe or dispense it, think, are we actually treating the right type of pain? And are we watching for sedation, falls, appropriate dosing for patient's kidney function, and risky combinations? I'd say that's how you keep this med from being a risky pain in the neck.
And we hopefully calmed your nerves about gabapentin claims that you credit and access evidence-based resources from pharmacist letter, pharmacy technician's letter, or prescriber insights.
And if you're not yet a subscriber or want to upgrade, you can save 10% with our exclusive listener code
Mhm.
RVT1026 at checkout. Easy link is in the show notes.
If you're already a subscriber, tap the claim credit link in the show notes or search your C organizer for this episode. And before we go, our favorite mailbag time. This time we got a listener question about our antibiotic stewardship episode. And it was, should patients stop antibiotics early if they feel better?
Good question. In fact, we tackled a claim in that episode that was true about limiting most outpatient antibiotic courses to 5 days. But we didn't want to pull today's episode off topic. So we answered it in a separate bonus episode, and it's already in your podcast feed.
Right. And if you're curious, just scroll your feed for the bonus mailbag and you'll find our full answer there.
Right. And if you have an aching question about gabapentin or neuropathic pain in general, and you want that answered next month, send us a message.
We also use your suggestions to plan our episodes. Email us at rumorversus.truth@trchealthcare.com or send us fan mail right from the podcast show notes. We really love some of our listeners to use the audio feature of that so we can actually hear your questions.
And join us next time where we'll talk about off label claims around ivermectin, which some states have made over the counter.
And we'll see which claims are overhyped. Thank you for joining us on Rumor versus Truth, your trusted source for facts, where we dissect the evidence behind risky rumors and reveal clinical truths. See you next time.